I'd like to let you know that Aussie Med Ed is supported by HealthShare. HealthShare is a digital health company that provides solutions for patients, GPs and specialists across Australia. Two of HealthShare products are Better Consult, a pre-consultation questionnaire that allows GPs to know a patient's agenda before the consult begins, as well as HealthShare's Specialist Referrals Directory, a specialist and allied health directory helping GPs find the right specialist.
20 years ago, many diagnoses relied on a good story, a careful examination, and a fair bit of clinical intuition. Today, radiology has become the third hand, the extra set of eyes, and sometimes a decisive voice in patient care. From life-saving interventional procedures to high-resolution imaging that reveals disease earlier than ever, radiology now sits at the centre of modern medicine. In this episode of Aussie Med Ed, we explore how imaging shapes clinical decisions, how students can better understand the tools available to them, and what the future holds for this rapidly evolving specialty.
G'day and welcome to Aussie Med Ed, the Aussie-style medical podcast, a pragmatic and relaxed medical podcast designed for medical students and general practitioners, where we explore relevant and practical medical topics with expert specialists. Hosted by myself, Gavin Nimon, an Orthopaedic Surgeon, this podcast provides insightful discussions to enhance your clinical knowledge without unnecessary jargon. I'd like to start the podcast by acknowledging the Kaurna people as the traditional custodians of the land on which this podcast is produced. I'd like to pay my respects to elders both past, present and emerging, and recognising their ongoing connection to land, waters and culture. I'd like to remind you that all the information presented today is just one opinion, and there are numerous ways of treating all medical conditions. It's just general advice and may vary depending upon the region in which you are practicing or being treated. The information may not be appropriate for your situation or health condition, and you should always seek the advice from your health professionals in the area in which you live.
It's my pleasure now to introduce Dr. Koukourou. He's an interventional radiologist who holds the position of Head of Interventional Radiology at the Flinders Medical Centre, and he's also a partner of Radiology SA. He serves as Head of Radiology at the Flinders Private Hospital, board member and Chair of the Clinical Governance Committee. Thanks, Adam, for coming on board Aussie Med Ed.
Thanks, Gav. Thanks for having me. It's been a long time coming to get this podcast up and running tonight. So as finally we managed to get the calendars lined up and get it happening.
No, it's brilliant to have you on board. Well, I thought we'd start off, over the past 20 years, how has imaging changed and how we diagnose, triage and manage patients across the hospital and primary care settings?
Yeah, thanks, Gavin. It's interesting you use that 20-year time frame because that's probably the time frame I've been doing radiology, certainly as a consultant, having graduated in 2006. And imaging has grown significantly in that time. In the early days of my training, there was obviously the plain X-ray was probably the most used modality, and absolutely that's still used today, and it serves a vital tool in some of the basic things, fractures, chests for looking at pneumonia or chest pathology, abdominal X-rays for bowel obstruction, for example. So plain X-rays are still widely used. CT was very limited. It was the old single slice CT, which it took 5 minutes to get a diagnostic CT head. That information is now captured in 5 seconds, essentially. It's very, very quick. And we've had significant improvement in other modalities. The quality of MRI has just gone from strength to strength to strength. The imaging that we can produce now in MRI has grown so much in those 20-year period. Other modalities have certainly come online as well. So there's the PET scan, positron emission tomography. That's more the role of the nuclear medicine team, but that's certainly come on, looking at metabolic activity of parts of the body, and very good in the role for tumour staging. How does radiology help the modern practitioner? Well, it's probably, I'm going to be very biased here, but it's probably the forefront of patient care. It's kind of the central hub, and everyone loops around that. Works complementary with the clinical team, our clinical colleagues. One of my old lecturers back in the late 90s has said history and examination was 95% of the diagnosis. But yeah, imaging is a complementary to that, and certainly helps diagnose those weird and wonderful things that you can't necessarily work out or capture clinically. You go, things aren't quite right. What imaging can we do? So the modern radiologist can certainly help in the spaces where the diagnosis may not be quite clear.
What do you consider the main limitations or pitfalls for imaging for clinicians?
The main limitations and pitfalls, well, some of it depending on where you're working, there may be a little bit of a time frame to get some imaging done. So that would be a limitation. Patients might have to wait. It's like anything. You go and ring your local tradesman or electrician to come and do some stuff. You may have to wait. And that is a bit of a limitation because we know with healthcare that we don't want to wait too long at all. So getting access to some of the imaging, particularly MRI, for example, can be a little bit of a wait. And some interventional procedures, if they are not life-threatening, there can also be a bit of a wait because of the supply-demand resource issues. So that would be one of the limitations for sure. Pitfalls that may potentially fall on ordering the wrong test. A patient has you think this is what I'm going to order for the patient has that test, but it's the incorrect one. So that's where conversation to avoid those pitfalls with your local radiologist to then determine the best pathway, avoid some of those pitfalls for sure.
And do you think there could also possibly be the scenario of like false negatives? So you get reassurance that something's okay and it's not quite right, and false positives where the opposite occurs as well?
Yeah, absolutely. So sometimes we look at something and go, that's abnormal. Maybe we overcall it. That's often where the clinical scenario needs to go. And yeah, this isn't quite right. Don't know what it is. Maybe it's this. And that causes a lot of anxiety, stress for everyone involved.
Obviously, radiology's changed a lot over the years. Where do you think things are heading for the future? And what about the role of artificial intelligence?
Yeah. So we're already seeing artificial intelligence come into radiology, and it's an adjunct. It helps. So we know certainly in the public sector where I work at Flinders, we have a chest X-ray AI program called Annalise, which helps identify pathology. That's complementary to your own skills. There's one coming for CT Ed. So it's just a little pop-up that just highlights potential abnormalities to make sure that you can capture those in your review areas. It's moving fast. We have AI software to pick up lung nodules as well. And these are tiny 1-2 millimeter nodules. So that is useful as well. But like most of these things, you can't rely on it completely. It's a help. The ultimate onus lies with us as the radiologists, not on the AI. So it's complementary, but not the solution to doing the work for us.
Yeah.
And of course, how do the referrers or the clinicians talk to an AI program to get the answer when they want to discuss their patients' findings? I don't think that's quite worked yet.
Yeah. There's no concern amongst the trainees that the AI might take their jobs for the future, or?
No, look, I don't think so. No, I don't think so. So I've seen the role of the radiologist evolve over many years. The old adage, sit in a dark room, turn the lights on with the films and don't come and talk to us, versus out of that space and into the realms of the MDTs being part of patient care, which being biased, mentioned earlier, at the centre of it. We are involved with helping determine treatment pathways and advising what next follow-up might be. I'm not sure AI can necessarily replace that. And there's a human side of things as well, isn't there? I think as a patient, you want to be able to see a face. So I don't think necessarily that's going to be a problem at this point in time. Of course, AI can't do any of the interventional procedures that I do. There is robotics machines around, but I haven't really seen them take off and do things without a human involved. So I'm not too concerned about that. I think they've been talking about AI replacing radiology for many years, but I'm still yet to see that.
Well, one of the things I have seen replaced over the years is the old films. So now it's all online and we can actually access them easily. In fact, the hardest part for me is actually finding out where the person actually went so I can actually look at the correct IntelliViewer site. So I've found that a real help in assessing patients, both finding out what investigations they've had done and also seeing how they've changed over that time as well.
Yeah.
What are your thoughts on the online viewing of radiology?
It's fabulous. It's absolutely fabulous. It's been game-changing for everyone involved. It makes things a lot more efficient for us to be able to capture that data electronically. You're not storing a whole lot of films. You can review things quite quickly and succinctly. It's very easy to have a conversation with the referrer about images because they can just ring you up and say, can you have a look at this for me? And as you said, you need to potentially look at multiple different platforms to try and find where these images might be, but you can do it very quickly and succinctly and get the answer that the patient needs when it's compared to previous, or have the conversation with the clinical team regarding, can you just have a look at a few of these other studies? You don't have to wait for the films to be couriered from somewhere else, or the patient to bring their films, which invariably might get lost over the journey. So look, it's been fabulous. It's been really good in improving patient care, getting accurate diagnoses, and producing reports which are more succinct, because rather than saying, please look at the old films in our report because we don't have access to the hard copy of the films, we can easily find where they might be and then compare them and give the answer that's needed. There's been no change in this spot, case closed. So it's been fabulous.
Yeah. On that basis, Adam, a couple of thoughts come to mind about the IntelliViewer type imaging. Yep. First of all, often I use the online measurings to measure size of fractures or displacement. How accurate are they? First up. Yeah.
They're much more accurate than what the old crayon texture ruler drawing, because there's that error that you get with the X-ray and the patient and divergence. So far more accurate now. Absolutely, it's fabulous. We can use some of the software to measure volumes of structures. So the respiratory physicians are quite keen in looking at lung nodule volume and seeing how a nodule might change in terms of volume over time. That makes it simple. That would be dead near impossible with the old films, Gavin. So yeah, that is really accurate for sure.
Well, the other thing that comes to mind too is sustainability too. I'm quite into that. And the whole idea of all these films, that would have been a bit of an impost on the recycling.
There are companies that do recycle some of the materials within the films, but the less films produced must be good. I think that must be seen as a positive. Yeah.
Yeah, excellent. Okay, what about the whole idea of over-ordering too? I mean, obviously with such availability of investigations, it must be tricky not to over-investigate.
Yeah, look, I think so. I mean, it's very simple to obviously write a form and let's get this test, let's get that test. But I suppose it depends on what the clinical scenario with the patient, how anxious the patient might be. Are we happy with the answer that we're getting? And probably the best way to get around that is to say, right, what is the exact problem that we want? What is going to be the best study to get me that answer? We'll go to that first. And that would be a conversation with your radiologist that can help guide you in the right direction. Because if you had said, I've got a patient in front of me, I just want one test to give me the answer on this problem, what would you say? So, for example, if someone had clear Achilles tendon inflammation, you go, should I do an MRI? You go, well, you could, but that might be a little bit of overkill. Why don't you just do an ultrasound? That may give you all the information that you need. And then you don't waste resources, time, patients, money on an unnecessary test. So I think it's about having a clear understanding of exactly what the clinical scenario is. I think we'll find that with some of obviously for a lot of the musculoskeletal studies, MRI is very, very useful, but there are some restrictions with access to that, of course. But I think we'll find in a few years with the government releasing some of those restrictions, that will become more accessible. And so you might find that less double handling of images or patient conditions will occur with that. So that would be very useful.
Yeah. I mean, I would have thought too, the ability to actually review the IntelliViewer sites and look at other imaging done in other areas would help reduce the chance of double ordering as well. So
absolutely. So sometimes a patient, the GP may be right onto it, get the diagnosis, but a patient may present to hospital for another complaint, and they may then get a repeat test, which the GP's already done. So access to software where possible means that you don't pre-order a test.
What about a junior doctor who starts out and they're not sure whether they should order an investigation? What are your thoughts? What would you say to the interns when they're unsure? What are their
Well,
process they should go through?
yeah, absolutely. So always review the patient's history, go through their notes where possible, work out what investigations they've had already. They may have already had a test for the same presentation or the same clinical complaint. If that's not helping or not getting the answer that they want, then come and have a chat to us down in radiology and try and work out what's going to be the best pathway rather than just filling out a form, putting it in, and then coming back the next day. That's going to be the best way that we can limit resource wastage. And particularly for the interns, it's all about learning. It's all about getting education. It's all about how can we make sure that we're doing the right things. And that's an excellent way to learn about what's going to be helpful for your patient in those situations.
I'd like to let you know that Aussie Med Ed is sponsored by Heidi Health, who provide Heidi AI transcription platform. The team at Heidi have told me that Heidi is the AI scribe built in Australia and trusted in nearly 2 million consults every week. The Heidi team have told me that students and trainees get free access to Heidi Pro, which they believe will aid quicker, smarter notes, allowing more time for patients, learning and rest. To learn more about the Pro account, visit heidihealth.com/pod.
It's interesting. Sometimes we get these request forms for, oh, can I have this CT scan? I'm worried about some arterial pathology in the abdomen. You get the patient down, you got any allergies? Oh, yeah, I'm allergic to intravenous contrast. It's like, so that information, if you grab that information prior to ordering that test, then you wouldn't have wasted the resources of actually getting them down to the department. So how do you work out to get to the answer? So just, do a bit of research before you put the order in.
Yeah. Dad, and what makes a good imaging request form then?
Yes, what makes a good request form is having the contact details on the form. That makes a good request form because quite often we are finding a lot of pathology that needs urgent attention and we can never find the referrer. It's a squiggle, it's not a name, it's not clear, there's no contact details on the form. So I think that makes a really good request form. In terms of the diagnosis, I think the information needs to be succinct. What the presentation is, a couple of brief differentials, and what you're hoping to find, therefore, with the imaging. And that would make a really good request form. And of course, with those contact details, if you're not sure, say, can you please call me to discuss or something like that. So those sort of things all help. Obviously, it needs to be signed and dated correctly and whatnot, and need to be able to read the writing.
Yeah, exactly. So obviously I can't speak because my handwriting's terrible, so I always try and type them up. But a thought of mine, I like to make myself accessible to my referring doctors and patients. And obviously sometimes people are scared to ring some of the specialists and ask information. You've implied that that's not the case at all in radiology.
Well, I can only speak for myself and some of my colleagues that I work closely with, and absolutely, we're always happy to take a phone call. I think people are more appreciative when you do have a conversation and you make yourself accessible. I get it. I'm learning all the time as well. And I understand how challenging it can be with a patient across the desk saying, Doc, I'm not well. What's wrong with me? I'm more than happy to have a conversation. I've got a number of people that I get messages from all the time. It's actually quite rewarding. It gets a bit busy sometimes, like, okay, whose message do I need to get back to? But it's actually quite rewarding knowing you can help in part of the patient's journey, and you can help your colleagues as well. Because at the end of the day, we're all here to help our patients and help each other. I don't think we're working against each other. So how can we best do that? Sometimes it can be a bit challenging getting through phone lines like a call center. Sometimes you're on hold and whatnot. But I think if you have a good relationship with your radiologist, just ask them if you don't mind getting their personal details, even email address, and send an email and we'll get back to you. And I think that's probably the best way to help do that. I work mainly down at Flinders, and I think that the specialists that I work with there and the GPs and locally, they're all fabulous. They're really, really good and always happy to have a conversation, either bringing me or I have a phone call with them. And I get a lot out of that too.
What about trying to learn more about radiology for the young students and GPs who want to understand how to interpret the x-rays better? Obviously, they can look at the films themselves and read your reports, but is there any other resources apart from speaking to yourselves and asking advice? Is there anything they could actually look at to actually try and help them understand things better?
Absolutely. There's lots of websites that do capture how to look at an x-ray. A lot of that information wasn't online when I did my training, so it was all old school, go to the library, find us a book and read through the books. So that's all different now, but it's very simple to get that information. And there's some great Australian websites as well that can help do that for you. But I'm always happy to take a phone call and give some advice if someone wants to come and see me. That's not a problem at all. I can help point someone in the right direction.
Brilliant. Well, if we start with the basics for the medical students, so if we go through a few different areas, we start with respiratory, chest x-ray versus CT's chest.
Chest x-ray, absolutely. It's quick, simple, easy to obtain. There's a chest x-ray in every street corner, essentially. It's the forefront of diagnosis. If someone's got shortness of breath, I don't think you'd go first and get a CT scan. It's a little bit more, I suppose, invasive. There's slightly more radiation than normal chest x-ray. Normal chest x-ray, 1 or 2 days of background radiation that we all get walking around. CT scans, a little bit more than that. Having said that, some of the lower dose CTs that we're now producing with the advances in technology in the last few years, that does reduce the radiation dose. But shortness of breath, chest x-ray, if it shows a pneumothorax, you've got your diagnosis, there's no need to perform a CT chest. The chest x-ray is normal, it's normal, and that's when you might go, okay, what other imaging modalities do we have in the chest imaging space to review pathology? And probably, yes, correct, the CT chest would be the next line of investigation, but I'd certainly encourage a chest x-ray to be done first. Not only can it give you an early diagnosis, for example, of a pneumothorax or even pneumonia, it gives you a baseline to then be able to follow the disease progression during treatment. So pneumothorax, for example, if it's volume of, say, 40%, manage it conservatively, chest x-ray the next day, the volume's reducing. So that it gives you a nice baseline. So I'd always recommend a chest x-ray for sure. So absolutely, it's still gold standard, in my opinion.
When they're in hospital and you're worried about a pulmonary embolus, what's the role of a CT pulmonary angiography versus the old VQ scans? And is there still a role for a VQ scan?
Yeah, look, there is. I'm not a nuclear medicine physician, but people go for the CTPA because it's a quicker test. The scanning is available 24/7 nowadays. Nuclear medicine may require, after hours at least, an on-call process. Nuclear medicine, from my understanding, if there are some abnormalities on a chest x-ray, pleural effusion or pneumonia, then it may make the diagnosis on a VQ scan a little bit challenging. And so the CTPA will give us the ability to look at the pulmonary arteries. It will also show any other pathology. Often patients who are in hospital do have comorbidities, which you won't necessarily pick up on a Q scan in isolation. And so a negative CTPA, so with no pulmonary embolus, a CT will give you a look at other pathology, the aorta, for example, the cardiac structures, for example, even the upper abdominal structures. So it just gives you a little bit more information than what the VQ scan. Yes, I think there's still a role for the VQ scan. Clinicians still worried about pulmonary embolus. If a CT is normal, a chest x-ray is normal, then the VQ scan does have a role to play for sure.
When we look at cardiology, obviously everyone will talk about an ECG as the first line test, but when it comes to radiology and imaging, where's the role of, say, plain x-rays looking at the size of the heart versus a echocardiogram versus other things like cardiac MRIs or CT coronary angiography?
Yeah, look, chest x-ray, as I said before, that's gold standard. Let's do one of those. Low radiation, easy to get to, looks at the cardiac size and lung fields. And if that's all okay, then you probably tick the box. If there's an abnormality on that, so a big heart, then the cardiologist may suggest an echocardiogram to look at cardiac function, cardiac output flow through the valves, look at the overall size of the ventricles, what their contractility is. The next line of investigation, if it's a coronary artery problem, so you're looking at stenosis, calcification, then it'll be a CT coronary angiogram in the right patient cohort, and that will be determined by the cardiologist, of course. Otherwise, looking at functional studies of the heart, the MRI is very, very good, but it does take a little bit of time. It takes up to an hour to do all the phases and the images of the heart, looking at the ventricles and the atrium contractility and flow through the valves. Whereas an echocardiogram is very simple. It's an ultrasound underneath the sternum or underneath the chest. There's no radiation involved. And for patients that are claustrophobic, or they have a pacemaker, some of the newer pacemakers are all MRI compatible, or the patient has some contraindication MRI. So an echocardiogram is a very simple test to do as a first line to look at cardiac function.
Right. What about general surgery? I used to learn about doing lateral decubitus x-rays looking for gas bubbles.
Yeah.
I presume those things aren't quite as commonly used nowadays, and there's more appropriate investigations.
Yeah, look, not as common. They're still done, absolutely, particularly when you are looking at following the degree of bowel dilatation, the setting of a bowel obstruction, for example. But you're right. I think a clinical assessment that suggests there is some intra-abdominal pathology, then a CT scan would probably be the pathway to go down, because the abdominal CT is going to show us a lot of pathology. It's going to look at all the abdominal organs. So someone who has radiolac fossa pain, for example, right-sided abdominal pain. So you may be saying query appendicitis, looking for gallstones, inflammation of the pancreas, some liver pathology, even bowel obstructions, looking for the level obstructions. The CT just gives you a little bit more information. Of course, the radiation dose is a lot more than what you would for an X-ray. So CT abdomen, pelvis, probably 2.5 years of background radiation. A normal abdominal X-ray won't necessarily exclude intra-abdominal pathology. So a CT is probably, certainly in the general surgical space, becoming more and more used. And people don't seem to think twice about ordering a CT abdomen pelvis, because it just does give us so much information. Also looks at the vascular structures, and quite commonly we do find some incidental findings that, oh, that's the answer. We'd never found that at abdominal X-ray. Bowel ischemia, mesenteric thrombosis, for example. So it gives us a lot of information.
Right. How does that compare to an ultrasound in that scenario?
Yeah.
Is that being less used?
Complementary. So I talked about before appendicitis or gallstone. So in young kids, absolutely, we want to try and avoid radiation where possible. And ultrasound would be the first pathway we would go to. But we don't always see the appendix on ultrasound, because if the bowel gas gets in the way, depending on where the appendix is sitting, if it's behind the cecum, for example, you won't see it. So a negative or an ultrasound that doesn't show the appendix can't rule out appendicitis, but it still has a role, and I'd definitely suggest that, particularly in the young patients. Gallstones I talked about earlier, you won't necessarily see all gallstones on CT. Some of them aren't radio-opaque, so they won't show up on the CT, so an ultrasound is required for that. That also gives us a better review of the gallbladder wall, which you won't necessarily appreciate on CT. So it's a complementary study. We know that liver lesions are quite common, be that incidental or liver lesions that we are following, and so ultrasound can help to determine whether something might be solid or cystic, for example, a simple cyst. I think if you're purely looking for renal pathology, renal function decreasing, you probably wouldn't go for a CT first up. You'd go for an ultrasound in that instance, because we know that some of the contrast dye that we use, we call it contrast dye, it's an intravenous medium that is used to highlight intra-abdominal structures. We know that can have an effect on renal function and is contraindicated in patients who have poor renal function. And so we'd definitely do an ultrasound, look for any structural abnormalities, obstruction, for example, renal stones perhaps. So it's complementary to that. Having talked about renal stones, that then goes back to, if someone's got a good history of renal colic, right side of flank pain, hematuria, then the modality of choice for investigation would be a CT, because that will show us the Shone's nicely. And in those instances, we don't often give the intravenous contrast dye. So if the renal function was a bit off, then that wouldn't cause a problem.
Brilliant. Well, when it comes to my area of musculoskeletal medicine, I like to think of things like plain X-rays and ultrasounds and axial imaging and CT and MRI. What are your thoughts on musculoskeletal imaging?
Look, I think it goes back to what I said at the start, history and examination. I suspect, Gavin, someone like yourself, patient comes in with shoulder pain or whatnot, and you can probably get a pretty good idea of what the pathology is. And absolutely, you don't want to be caught by anything. So plain X-ray and ultrasound's a fabulous start, low radiation, simple tests, relatively easy to get, and it will probably give us all the information. We know that ultrasound is fabulous at looking at moving parts, moving tendons, ligaments, looking for joint fluid. It's fabulous in that, and probably gives you enough information to go down your treatment pathway. We use ultrasound as well for therapeutic interventions. It's how we do a lot of our injections for bursal inflammation, for example. So that's certainly the first line. The only challenges are that the intra-articular pathology we won't necessarily appreciate accurately with plain X-ray or ultrasound. So plain X-ray will show us all the bony structures. It won't show the intrinsic cartilage and ligaments. Ultrasound shows the extrinsic soft tissue structures, tendons, bursa, but won't also show us internally. So then we need to look at what other modalities may be available to us. Now, years ago, we used to go for CT arthrography to look at internal structures, just show us the outline of what the ligaments might look like, or outlines of what the labrum, for example, in the hip or shoulder might look like. And that was quite good, but it's semi-invasive. It's a needle into a joint space, which does run the risk of causing further intra-articular problems, inflammation or infection, for example. So with MRI improving its ability to image these body parts, as I said earlier, then we've moved more from, rather than doing CT arthrography, moved more to MRI to look at the intrinsic structures. Knee is probably one of the more common musculoskeletal referred body part that we get, and the MRI is the gold standard for looking at what I would call internal derangement, cartilage defects, meniscal injuries, cruciate injuries, and that's probably the pathway you'd go. It also, if someone had a history of significant trauma, then you would probably you would do an X-ray first just to make sure that there wasn't a fracture, for example. In those settings where there is a fracture, CT is fabulous for that. It really shows the extent of the fracture, the articular surfaces. So in that space, that's where CT is. But if you're looking at intra-articular pathology, MRI is definitely the way to go.
What about the role of MRI arthrogram?
So once again, when MRI quality wasn't as great, now I'm probably going back 8 to 10 years, we used to do MR arthrography for the hip and shoulder quite a lot, and even the wrist. It shows some fabulous pictures, but I think with the stronger magnets that are being produced now, that we really get a good understanding of what's going inside joint spaces without performing the arthrography. So I think the indication for that is probably a little bit less. You may consider that if the MRI without arthrography was inconclusive and you're still clinically worried about intra-articular pathology, like in the shoulder for a small labral tear, that's when you'd probably do arthrography. But I think that would probably be a discussion with the radiologist regarding, these are my clinical concerns I have with this patient. Let's have a look at the imaging. Can we go through that? Is there something you can see? Do we then need to go onto an arthrogram to further review that?
Right. The scenario of emergency medicine, the old trauma scenario, the old trauma X-ray, the chest X-ray, pelvis and cervical spine, I see that more and more being replaced by a rapid CT scan. Is that the scenario?
It is, absolutely. Look, we still do, a quick survey, because most of the trauma rooms have an X-ray inbuilt in the resuscitation room. So a quick survey with a lateral C-spine, chest X-ray and pelvic X-ray still does occur, because it may help guide a pathway. If someone, for example, is hemodynamically unstable, they have a significant pelvic fracture, then you can stabilize that. Or if they've had a chest X-ray, they've got a hemothorax, then you'll deal with that in the resus, help stabilize the patient. And absolutely, the lateral cervical spine in case there's significant distraction injury. So all those acute problems can be managed at the bedside, if so to speak, in the resus room before the patient then goes to have a CT. And of course, we only do multi-trauma CTs in a stable patient, because you don't want to have an unstable patient in your CT scan. It becomes a bit of a challenge for everyone. So they're complementary, like most of the things, complementary, but not necessarily being replaced. But we are seeing more what you call multi-trauma CTs, head, chest, pelvis and neck. It gives us a lot of information in a short period of time. Going back to what I mentioned 20 years ago, one slice CTs, 5 minutes for a CT head, there's no way we could have done multi-region CTs in a short period of time. It would take two hours. And for the image reconstruction, now things are a lot faster. We can get all that information and find out exactly what the pathology is to help then guide the patient management. So it's crucial, the multi-trauma CTs now. It's a bane of our existence because the number of images is significant, but it certainly helps for sure.
Excellent. And I'm a young medical student coming through and watching Aussie Med Ed, inspired by
Yep.
yourself speaking today on the YouTube. What's the pathway of becoming a radiologist in Australia? How does it actually work from medical school?
Yeah, so the training is a 5-year program, which is a general radiology program capturing all parts of the body, all modalities, all the way from kids to the elderly. It captures everything. So it's a 5-year program. For those wanting to do a fellowship or subspecialty, so example, interventional radiology, so it might be an extra couple of years on top of that. So you could be looking at up to 7 years training in radiology to get to where you need to get to.
And exams along the way?
Yeah, look, there are. Long time since I did them, of course. It's all changed nowadays, but I think there's a anatomy, physics, pathology, radiodiagnosis. There may be some, and that might be a combination of oral and written exams as well, but I'm not close to the training program or the exam pathway. It seems to keep changing and changing for the good, of course. There's reasons why all education changes as the journey, but yes, absolutely. There's certainly exams along the way.
What would be the most rewarding part of being a radiologist, do you think?
For mine, it's just seeing the patient smile at the end of the bed. When, for me, for the interventional side of things, when they've had a great outcome and they come back and see you in 2 years' time and say, look, I had a fabulous outcome and I'm just here to have another injection, for example. So you get a lot out of that. I think that's really rewarding. When you get a diagnosis that's crucial to the patient's pathway from the diagnostic space, you don't necessarily get that feedback unless you're speaking with your clinical colleagues, or they might let you know. I had a patient the other night. I was doing some reporting on Friday night and had some significant pathology, and I luckily managed to get onto the GP after hours, which I was thrilled with. And the patient had, almost life-threatening pathology, or if it wasn't treated, would have become life-threatening. And to be able to pass that information on, look at the images, know that that patient was going to get the correct care at a short period of time I find that fabulous as well.
Yeah, it's interesting. You're saying very similar things that I say about orthopaedics as well. And it sounds like the evolving role of the radiologist is becoming more as part of the whole team as opposed to being separate on the sidelines.
Yeah, look, it is. That's right. And so we keep getting told all the time, and rightly, if you find a significant abnormality, then you need to phone it through. And even incidental findings that may or may not be significant, you need to phone it through. And so we are always and more moving to that space of becoming primarily involved in the patient's care, because we just don't want anything to slip through the system. We don't want anything to slip through the cracks. The MDTs have evolved, for sure, that it's a multidisciplinary team. And if I look at my role at Flinders, HCC, so hepatocellular carcinoma liver transplant unit, and that's obviously we've got the hepatologists, the surgeons, the radiation oncologists, the oncologists. And that's just grown over the number of years. And so we're kind of sitting there in the middle going, right, this is what the imaging is showing. This is what the potential treatment pathways might be. What do we all think about this? So you're almost like the chair, but you're not of the meeting, because if you don't give the right information on the imaging, the patient's not going to get the right treatment. So it's a really important role.
It must be very rewarding.
Oh, look, it is, absolutely. It gets a bit busy sometimes, but everyone else I speak to just finds how rewarding those MDTs are and how reliant they are on radiology. I think over time, patient care has significantly improved so that multiple people are giving an opinion and guiding what the pathway of treatment is so the patient gets the right treatment. I think that's really important.
Excellent. That's brilliant. Well, it's interesting hearing how radiology's changed. Where do you think things will head for the radiologists in the future? Any extra things that are on the pipeline in radiology and technology?
In the interventional space, there's always new little tools and tricks and doing newer procedures that might come around. So I think that will continue to grow, the minimally invasive treatment pathways. We've certainly seen the growth of interventional neuroradiology in the last 15 years, and that's been a massive uptick in terms of what can be done neurovascularly by a pinhole, essentially. That's been really good, and there'll probably be some more growth in that space. I do a lot of body interventional work, so kidneys and liver stuff. And yeah, we're seeing new treatment pathways in that as well. So I think that's where there'll be some growth. And as we talked about earlier, probably AI making things a little bit easier for the diagnostic realm. Technology is always going to get a little bit faster, a little bit quicker, and the resolution of images are going to be better. So we're going to see the ability to see more parts of the body at a closer level to make it easier to get a diagnosis. So I think that's where it's going to go.
Yeah, I saw a wrist MRI the other day and I was just in awe how good the quality was.
Yeah, you certainly do notice good quality versus a suboptimal quality. You notice the difference for sure. It makes it very easy for the clinicians to go, well, you know what, I can actually see exactly what that looks like. And you can picture that in your head if you're doing the operation. You go, well, this is exactly what it's looked like. And you can cross-reference, which is certainly what I do with the interventional space. I can look at the image and go, right, I know exactly where that's going to be. I know exactly what it's going to look like. And you get that 3D dimensional thing ahead from the images from that. So I think that's really helpful for sure.
Yeah. Now, showing my age here, I remember this new thing that has just been invented called MRI, and we're talking about how it might influence medicine. Is there anything like that coming out? Obviously, AI is probably the equivalent in that sense, but anything more investigational that, apart from AI, that might be on the horizon?
Yeah, look, I think some molecular imaging, getting down to the molecular level, is probably going to be where things are further growth in PET scanning, looking at functionality of lesions for tumours, for example, the biology of the tumour. I reckon that's probably where it will go. And we know that some of the newer immunotherapies treatment pathways are being used in conjunction with imaging to then help guide treatment. So it's going to be a combination of treatment with current imaging, and the molecular stuff I think is probably where it's going to be the new bastion, I would have thought, in terms of new technology.
Well, Adam, it's been fantastic having you on tonight on Aussie Med Ed, and thank you very much for giving up your time. So thank you very much for coming on Aussie Med Ed.
Thanks for having me, Gavin. It's been a fabulous evening, fabulous discussion. I hope the listeners get something out of it tonight, and I'm happy to help out. No problems at all.
No worries. Thanks very much.
Thanks, Gavin.
Thanks again for listening to the podcast, and please subscribe to the podcast for the next episode. Until then, please stay safe.
I'd like to let you know that Aussie Med Ed is sponsored by Avant, Medical Legal Indemnity Insurance. They tell me they offer holistic support to help the doctor practice safely and believe they have extensive cover that's continually evolving to meet your needs in the ever-changing regulatory environment. They have a specialist medical indemnity team located here in Australia and have access to medical legal experts 24/7 in emergencies.